this sort of tricky title was set by the scientific committee chair, Dr. Basu, and I myself was trying to figure out what I'm supposed to talk about. But actually, in a very subtle way, he's twisted it from fragile to brittle or brittle to fragile. So we're really talking of brittle diabetes in the past, but now we're going to talk of fragile diabetes, but not really fragile diabetes. We're going to talk of fragile bones in diabetes. So we move from brittle diabetes, which remains an entity which is still discussed and debated, to fragile diabetes, which is not really fragile diabetes, but basically that bones in diabetes are fragile. And this topic was chosen because the idea is to sensitize people, including our educator friends and all of us, about the fact that this is an important area in diabetes. And you heard a wonderful, wonderful presentation on diabetic foot. And similarly, I'm sure we are aware of kidney in diabetes, we are aware of heart in diabetes, we are aware of so many things. But there's another area of diabetes which has often been neglected or is relatively recent. And I think it needs attention of all physicians as well as our educator friends. So this is part of the team, that I moved a few months back, and shortly after I moved, a couple of months, and then COVID came, and so everything was like a statue for some time. This is part of the group. So when we talk of complications of diabetes, we are looking at this poor diabetic patient who's already worried about his feet. You just heard all that, about his kidney, about his eyes, about stroke, dental issues, cardiac issues, erectile dysfunction, feet. And yet, to complicate his life further, we are adding something there. And that is, we are talking of actually an increase in bone density, increase in bone fracture risk. So increase in the risk of developing a fragility fracture. Is that true? Should we be looking at these in a diabetic or not? Why should we do this? Is it at all relevant, or is it just someone trying to push another thing into the gamut of diabetes and try and sell a product? Unfortunately, that's not true. This is an association between diabetes and reduced bone mass, was described by none less than Albright and Riefenstein in 1948. I think they described everything in endocrinology, from hypoparathyroidism, hyperparathyroidism, androgen insensitivity syndrome, and even osteopenia in juvenile diabetes. And then it disappeared from the scene till it came back in a couple of papers in 1980 and 1990 talking about osteopenia, largely talking about juvenile diabetes, where it's well established that a reduced bone density and increased risk of fracture is common in people with type 1 diabetes who live long enough. Now, there are lots of data on this, but I'm choosing just this one meta-analysis, which is looking at type 2 diabetes. So as far as type 1 is concerned, people with type 1 diabetes have a much greater risk of fracture. We don't see it so much because we don't see too many type 1 diabetics in middle age and old age, but now we are seeing more and more. And once we are seeing that more and more, and especially some varieties of type 1 diabetes that come on later in life, you're actually likely to see more and more impact of type 1 diabetes on bone, but we won't talk about that today. Let's talk about the garden variety of diabetes, the common garden variety type 2 diabetes. And if this is the most sort of conservative estimate of relative risk of 1.7 for hip fracture. We know that hip fracture is the most devastating consequence of osteoporosis. So if you had to have one fracture that is bad, one would think of hip fracture because it has significant morbidity and also even significant mortality. So, and people with diabetes in many studies, Westergaard, etc., have shown 3 to 4 times greater risk. But if you take a very conservative estimate, even then, 1.7 times relative risk of hip fracture in people with type 2 diabetes. Now, to look at this further, we did a small study with Dr. Mohan's group, where we were looking at self-reported fracture. All of you are aware of the ICMR in-diab population study. You know that's one of the landmark studies in India. And there we just looked at self-reported fractures. We put that in the questionnaire when the questionnaire was being designed. And even that showed something interesting. If you look at diabetes, pre-diabetes, and no diabetes, you find greater prevalence of fractures in people with diabetes, this one, as compared to those without diabetes. So quite clearly, there seem to be, of course, this is self-reported fracture. This is no classification of osteoporosis, non-osteoporosis, nothing. But overall fractures were higher in people with diabetes. And the strength of the study, of course, is large numbers. And of course, we know that relative risk was about 1.3 in this. Now, without going too much into that study, I will just say in one line, the study that was published a couple of months ago clearly showed that people with diabetes have more self-reported fractures in a community setting of in-diab study as compared to those without diabetes. So fractures are common in people with diabetes. This study can only conclude that much. Now, when you look at within diabetes, it's interesting that Lee et al. Showed that as you go from an A1C of really tight control of around 6 to more than over 10, the risk of hip fracture goes on increasing. So as you go from 6 to 10, your risk of fracture increases. Now, this does not necessarily mean that this is directly linked to diabetes control. It could be a reverse causality, but nevertheless, it does show that a typical poorly controlled diabetic with multiple comorbidities, not looking after themselves, duration of diabetes being longer, have a greater risk of hip fracture incidence than a young diabetic who's trying hard and is well controlled. Now, the issue here is about bone density, and many of you will already be writing questions that, but bone density is increased in type 2 diabetes, and that is correct. If you have two people, one with type 2 diabetes and one with no diabetes, the bone density is slightly higher in people with type 2 diabetes for various reasons, including higher insulin levels initially and whatever. But unfortunately, this higher bone density doesn't translate into better bones. In this case, a slightly higher bone density in people with diabetes still confers a greater risk of fracture. Within the diabetes group, again, those who have lower BMDs will have greater risk of fracture. Those who have higher BMDs will be protected to some extent. But if you compare diabetes versus non-diabetes, then you will find that people with diabetes tend to have a greater fracture risk, even though their bone density may be slightly higher. This is an important point to understand. And one of the things that happens is when you follow up people with diabetes, the rate of bone loss is higher. So if two people are starting out today, one is a diabetic, one is a non-diabetic, and if you look at the rate of bone loss, it is higher. And this is the person with prevalent diabetes. The slope is steeper here, right? Femoral neck here. And look at the slope here. This is non-diabetes. So you see a sharper decline in bone loss, in bone mass in people with diabetes than without diabetes, even though the baseline bone density is higher, right? That's an important concept to understand. And why is the bone density misleading? Because the losses in diabetes are often of a different type. It is not that the bone density per se goes down, but the bone quality is affected. And one very good example is how cortical porosity is affected. This is a non-diabetic person's reconstruction with CT. And this is the bone of a person with diabetes. And you can see this remarkable porosity of the cortex. Look at this. The green parts are the porous parts. This is non-diabetic. This is person with diabetes. So this is really a history of rigidity fracture also. This person has clear-cut osteoporosis. This does not. But the bone density is not dramatically different because bone density doesn't actually factor in cortical porosity to a great extent, and also microarchitectural deterioration. And also, it's not just bone density. Sometimes we get stuck with bone density and we think that that's the only way to diagnose osteoporosis. The basic thing is risk of fracture, and the risk of fracture is greater in diabetes. Yes, bone quality is very important. Bone mass, as I told you, within the gamut of diabetes, within the spectrum of diabetes, if you have lower bone density, then you will have a greater chance of getting a fracture than a diabetes patient with higher bone density. There is a problem with bone turnover. These may well be linked to, again, the usual story of AGE deposition. They may also be linked to poor glucose control, again, leading to greater AGE deposition. But there's also other things. Don't forget fall risk as a big fracture risk in everybody. including those with diabetes. So people with diabetes have so many issues with vision, with neuromuscular coordination, with postural hypotension. Their fall risk is higher. If you have a higher fall risk, you will get more risk of fracture. Those who have significant microvascular complications also have reduced blood supply to the bones. And Dr. Pense was talking about it a little bit. And there also you get a greater fracture risk. And then there are anti-diabetic medications like pioglitazone, which can also cause an increased fracture risk. And not only that, there is still some suspicion about SGLT2 inhibitors, maybe in the long run, may be causing increased fracture risk. So all these things can be there. So how should we do? What should we do? Fracture, we are saying bone density is slightly higher. And how should we treat it? And that's what I'm going to spend the next 10 minutes on. How to predict fracture risk? I'm not talking about FRAX. I'm not talking about newer techniques, pentosodine, trabecular bone score. But it is important bone mineral density remains the keystone, remains our criterion, the primary criterion for determining fracture risk in diabetes. And I'll explain what I mean. Even though I'm saying that it's slightly higher in diabetes as compared to non-diabetes, but nevertheless, at every T-score level, the fracture risk is higher in diabetes. So again, one person with diabetes, one without diabetes, same T-score. For the same T-score, the person with diabetes has a 50% greater risk of fracture. Seen very well in this landmark paper by Schanborg in Lancet in September 2015. The green ones are bars are people without diabetes. The purple bars are those with diabetes. And as the 10-year risk of hip fracture goes up, as the bone density declines from left to right. So you go from left to right, lower bone density. At every bone density, the fracture risk is higher in the person with diabetes as compared to those without diabetes, indicating that, again, that for the same bone density, diabetics have a 50% greater risk of fracture. But also important to see that even in diabetes, and I'm rubbing home this point, as you go down in the bone density, the fracture risk does increase. People have used trabecular bone score, a fascinating area, and well, CMC Vellore is doing a lot of work on this. Very interesting area, but we're not talking about it just now. What are therapeutic considerations? Most recommendations represent good clinical practice rather than evidence-based guidelines. So the evidence is gleaned from people with diabetes that were included in large osteoporosis studies. Studies specifically in diabetes and in people with osteoporosis and diabetes, specifically for people with diabetes as a denominator, have not been completed yet. So it's more of an expert group, which I'm part of, the IOF bone and diabetes expert working group. What are the considerations? We avoid glitazones. Possibly think about SGLT2 inhibitors, at least in those who have frank osteoporosis. A bit of a question mark. Obviously, we know all that, aggressive prevention of diabetes complications. Assess and prevent falls. A neglected area in our country is fall prevention, and a big area for educators to get into. Shubha Banot in our team is well tuned with all this. She's also a bone educator, and you can train one of your diabetes educators to develop the skills of a bone educator also. Just look at fall prevention and proper handouts and simple instructions about fall prevention, because people don't talk about this at all. Of course, we have to make sure that calcium and D is all right. And selection of osteoporosis drugs is not different than in a non-diabetic individual. So far, there is no data to say that this drug is specific for diabetes in the osteoporosis armamentarium versus this drug is not good for diabetes. There is no such data yet. So we know that people with diabetes are at increased risk of hip fracture. We just discussed that. But we also know in general that they are at greater risk of post-hip fracture mortality. Overall, the fact is that hip fracture mortality because of hip fracture and even non-hip fracture, we can leave that, but hip fracture mortality is higher in people with diabetes. So regardless of the risk of diabetes per se being high, if a person with diabetes gets a fracture, there is clearly a greater risk of mortality and morbidity following that fracture. So good glucose control remains important for all of us, for every situation, we know that. But at the same time, as usual, hypoglycemic episodes have to be minimized. They should be minimized because hypoglycemia is a problem. And if you have a fall because of hypoglycemia, you can clearly fracture the bone. So hypoglycemic episodes have to be minimized for the heart, for cognitive function, but also for the bone. Glitazone should not be given to postmenopausal women with osteoporosis. SGLT2 inhibitors, keep a question mark. They're not all the same. There are different effects of different SGLT2 inhibitors, but more recent data indicates that the fracture risk is not high. So that's very encouraging for all of us who like to use SGLT2 inhibitors. But at the same time, one has to look at 10-year, 15-year data in the case of osteoporosis to really give that final answer. As you know, even with the glitazones, we discovered many years later. So it's a bit of a question mark. Don't hesitate to use right now. But if someone has frank osteoporosis and is on treatment for osteoporosis, perhaps if there's an option, you could choose other drugs. The other important point is that we are pushing for weight loss always in our diabetic patients, and many of them follow fat diets and crazy diets and trying to reverse diabetes. Sometimes the emphasis on exercise is not enough. Specific instructions about exercise are missing, and if you lose weight drastically without exercise, your bones will go for a toss. This happens even following bariatric surgery. There is a definite increased risk of fracture following bariatric surgery. You need to make sure there's enough calcium, vitamin D. We won't go into that. I will just make one line statement here, a one line statement. That is, when you use vitamin D, please make sure you're giving about 2000 IU a day, even if you have not measured. If you're measuring, you do it accordingly. But 2000 IU of vitamin D, successive studies have shown, works very well for people in India. We don't always respond to 600, 800 units as a practice in the West. Our baseline levels are often very low. As I'm discovering, we're trying to study vitamin D in COVID, and even now our baseline levels are quite low, 25%. In the first 50, the 25% were below 10 nanograms. So for us, with or without with measurement, one can use a different regimen. But in general, for educators and for everybody, 2000 IU, you can go to 1500 if you like. Don't use very high doses. We are already seeing vitamin D toxicity in our patients. So therefore, it's important not to use excessive doses also. But if you're in that zone without measurement also, you cannot go wrong with high or low vitamin D. And if you're obese, your patient is obese, you require a higher dose, because obesity is definitely a reason to use a higher vitamin D. You can use bisphosphonate, denosumab, teriparatide. That's not a problem. Any of these drugs work. And the last couple of slides, the take-home messages. And this is important because I left one question unanswered. After doing the bone density, how should we decide? What should we do? Because I already said bone density may be slightly higher. And the take-home message, which is from the IOF flow chart, which for lack of time I've excluded and complicated, people should screen all people with diabetes over 50, they say, but at least we should follow 60. All of us treat diabetes, and we should check a bone density in every diabetic over 60. If possible, economics not an issue, then maybe over 50. And the other important part is, instead of using a minus 2.5 as cutoff, you should use a minus 2 t-score as cutoff. So two important points here: lower age of screening and a better t-score as a cutoff. So you need to check your t-score, and even at minus 2.0, you may want to intervene or discuss with a specialist. Choice of drugs is same. Recommendations are still largely empirical, although more and more data. This has become a huge area of research, especially in basic science also. And Dr. Bhadada's team at Chandigarh is looking at that closely within India. And as I told you, Dr. Thomas Paul's team in Vellore is looking very closely at the trabecular bone score and its use in diabetes. So we have clinical and basic work going on in our country itself about osteoporosis and diabetes. And there's lots we don't know, but there's also something that we know, and we are learning more and more. And to know what we know, and we also need to know if we don't know. And there are many things I told you which we don't know, and I've specified that. That is true knowledge. That distinction is very important, not to get dogmatic, not to get empiric about anything. This is clearly known, and this is suspected or postulated. Thank you very much.